So I'm going to talk about the evidence base for the endoscopic treatment of large colorectal lesions. I'm going to cover lesion assessment and treatment selection, techniques to enhance complete resection, to minimise recurrence, and methods to anticipate and treat complications, and then if we have time, the role of ESD, which is actually a huge topic in itself. What are our goals when we're confronted with a laterally spreading or large sessile lesion? We want to safely, precisely, efficiently, and completely resect the target tissue, minimise invasiveness and avoid patient injury, avoid recurrence, and in particular, I think we have to optimise the therapy to the pathology. We can't over-treat, nor should we under-treat, and we have to consider these things such as expense, time, and opportunity cost. How much time is lost doing unnecessary, expensive procedures when we can already handle the procedure another way? You should always consider the underlying histological nature of the lesion, and this means appreciating the boundaries of the lesion and the sort of the colonic phenotype, and in particular understand whether it's an adenoma or a serrated lesion, because in the right colon, what appears to be an adenoma could be a large dysplastic focus in a large serrated lesion, and I think this is one of the explanations for interval cancer. When you look at a large sessile or laterally spreading lesion, if it's benign, it should have the sort of overall sense of homogeneity. In other words, when you look, there should be no obvious depression or large bulky nodule that's a different colour or has a different surface pattern. That's a very simple rule, but you see here, these are 3 lesions sent to our department for endoscopic resection, and when we look in overview in every single case, we can see the loss of homogeneity in these areas. There's a darker area, but more vascular area, and we focus closely, we see disruption to the microvascular pattern and also the pit pattern. So even if you don't know these classifications, these are obviously deeply invasive cancers. This can even be done with more primitive scopes. So this is a 180 series non-HD scope, and this is a doctor sent to us from the nation's capital. And you can see that relatively in overview mode, it's somewhat homogeneous, but when we look under MBI, we see this demarcated zone with loss of the underlying pit pattern type 4, and we see this type 5I pattern, irregular pits. So it should be cancer here in this area here. At least high-grade dysplasia. We need also to remember the excellent criteria that were put forward by Evelyn Decker and her group in Amsterdam, and these are the WASP criteria for characterising serrated lesions. And then once we know all that, and we can appreciate that we're not dealing with cancer, when we look at a lesion, we say, well, this is an adenoma, or it's a serrated lesion, or indeed we can say that it's a dysplastic focus within a large serrated lesion. And I hope you can appreciate here the classical serrated lesion and then this dysplastic focus in the clear demarcated zone. And this is highly important for endoscopic treatment of these lesions, because if we fail to appreciate that the area of dysplasia is actually drawn from a larger area of a advanced laterally spreading lesion, perhaps a serrated lesion, and we fail to remove all the tissue, then these are rapidly progressive lesions, and this patient is at risk of interval cancer. So this is a common thing that we see in our serrated polyposis patients when they're sent to us. And why are these patients at risk of interval cancer, and why are serrated lesions with dysplasia perhaps one of the main causes of interval cancer, aside from failed detection? And it's because these lesions are rapidly progressive. This is an excellent study published in Gut from Bettington and colleagues in Brisbane. And what it shows is that the age of the patient with a non-dysplastic serrated lesion is around 60 years of age. But the age of the patient with a dysplastic serrated lesion, this is a pathology study with molecular markers also built in, the age of the patient with a serrated lesion with dysplasia is the same age as the patient with a serrated pathway cancer. In other words, these lesions, serrated lesions with dysplasia, are rapidly progressive. And here's an example that we had in our own department. This is a patient referred to us for resection of a large laterally spreading lesion at the hepatic flexure, and we dropped down to the cecum and we noticed that they'd said they'd removed an adenoma there 6 months earlier, but in fact what they'd done is remove a dysplastic focus from a serrated lesion, and this is a serrated pathway cancer, would you believe? So good. So when we look under MBI, sorry, slides are just catching up. So when we look under NBI, it looks like really nothing. but in fact, when we take biopsies and then the patient goes for surgery, this is cancer buried in the colonic wall, so a T2N1 serrated pathway cancer, because the primary endoscopist failed to appreciate the true pathology of the lesion. So it's very, very important before you resect, always look carefully, understand the nature of the lesion and the full extent of the lesion, its relationship to other structures before you decide to remove the lesion. Also, having done all that and respected the lesion that you're dealing with, make sure that you make some evaluation of the rest of the colon, because many of these patients, at least in Doug Rex's experience and also in our own, about 20% have at least one other advanced adenoma, 2 centimetre or greater, somewhere in the colon, and a good proportion of those who are referred with serrated lesions actually have serrated polyposis syndrome. So again, extent, morphology, position, access, all of these things. Then you need to think, can I do this now, or should we bring this patient back? And do I have all the equipment that I need? Do I have enough time? Time's important. You don't want to be under pressure of time. And is this lesion better removed at a later date by a different team or another endoscopist? Here's all the evidence base for endoscopic resection, and this is something that you can look up in gastroenterology, and we've actually published many papers on the techniques, but definitely you need these things in terms of equipment. CO2 insufflation, microprocess-controlled electrosurgical generators, so you have fractionated current for effective tissue resection, minimising the depth of thermal injury, reducing the risk of post-EMR bleeding. It's best to use a colloidal solution. We showed in a randomised trial it's better, and we need the dye to define the edges of the resection and also the submucosal plane. The simple things that we need to do, this is not complex, but so often I don't see people doing this. Use gravity. If the lesion is within the fluid pool, make sure you rotate the patient so that the lesion is opposite the fluid pool. And this optimises the effect of gravity on tissue elevation, but also it gives you a clear working field should there be bleeding or a perforation during the procedure. So in this case, obviously a pedunculated lesion, and here we have major bleeding after we chop this off. But you know, you don't need to panic. You can take some time to take some photos. You can maybe tell a joke while they get the clip or the coag grasper, which is what we mainly use, and then you can deal with it. So there's lots of publications on this and the techniques. In particular, I refer you to one in GIE where we've gone through all the techniques and technical tips for EMR and also other types of polypectomy and emphasise some of the key aspects. These are using a dynamic injection technique. Start the injection before you stab the mucosa and recognise there are 4 possible outcomes. If there's no tissue elevation, you're transmural. You can get an intramucosal injection, and you can, of course, what you want to see is once the tissue starts to elevate, you draw back and use the needle to elevate the tissue into the lumen. We want to achieve complete excision, and this is how it's done. So this is a large lesion referred to us. And next to me here is Professor Steve Heitman from Calgary, Canada. He's the Director of Colorectal Cancer Screening there. And this video is really quite disturbing, not so much disturbing because of the size of the lesion, which is 10 centimetres long and full circumference, but the fact that Professor Heitman doesn't blink for the first 15 minutes of the video. So that may be uncomfortable for you, so we just chop him out. And so here we start with the injection, and then include a margin of normal tissue, aspirate gas so the footprint of the lesion is reduced, close the snare, use a staged snare closure so you don't just close quickly but close a little and then completely, and then we check mobility, cut through, and we can proceed very quickly to remove this lesion. You need to align the snare with the edge of the mucosal defect. Here we haven't included a margin of normal tissue, so maybe we leave a microdot of adenoma at the end, and I'll come to that as to why that might be the reason for recurrence. Because within the defect, I think if you operate in this way, you don't leave residual tissue within the defect. Sorry. And I can show you the end result. So we have a wide mucosal defect extending upwards over about 10 centimetres or so, nearly full circumference, and patient can actually go home same day or after single night admission, and these patients don't tend to have recurrence. This is consistently reproducible should you use these simple principles, which are not complex and really can be learned by anyone who's had training in advanced endoscopy. And of course, we've published extensively on outcomes, including fully circumferential resections. And in follow-up, we don't see recurrence in these patients, and we have other ways of minimising recurrence. So we have to, of course, ensure complete adenoma excision. Thermal ablation for visible residual adenoma doesn't work. We shouldn't be doing that. And finally, we need to consider this idea of thermal ablation of the post-EMR margin. So here we see a very clean EMR resection, and then what we do is we apply thermal ablation using snare tip soft coagulation. Same technique as we use for intraprocedural bleeding, which I think I demonstrated yesterday. Very simple, 80 watts effect 4, and you just coagulate the margin of the lesion. Very simple, and in a prospective multi-centre randomised controlled trial, including 430 patients randomised to snare tip or no snare tip in a blinded fashion, this reduced the risk of recurrence from 20% down to 5%, and in the high-risk group, where lesions above 4 centimetre, it actually was dramatically effective at first surveillance, surveillance colonoscopy 1. So this is really going to be the gold standard for EMR, is snare tip soft coagulation of the post-EMR margin. This paper is still sort of in editorial land, but it's all done, locked up, and we've actually started a large prospective validation study, multi-centre international, and the results are outstanding. We never see recurrence anymore. And this is how it looks. This is the case from yesterday. You probably didn't get to see this, but very simply it's done like this. And you can generate a nice coagulation effect at the marginal lesion just by tracing along like so. Very simple and precise. And the end result from yesterday's case is here. So this ended up being a circumferential resection. I haven't heard the histology yet, but extending upwards for more than 5 or 6 centimetres from the anal verge, and then downwards to the anal canal, across the hemorrhoids and onto the squamous mucosa. The patient's completely fine today, no pain, a little bit of discomfort in the rectum, actually ready to go home, and we put this patient on steroid budenophoric enemas for about 6 weeks. These are hemorrhoids here. Probably will need a dilatation. So having done all that, what about risk factors for complications? So I think bleeding, we know, right colon location, we don't have an effective treatment. Perforation is not common now with EMR, 1 or 2%, and there are stigmata that you should look for that are not frank perforations at the time of the resection, which alert you to the possibility. This has been published in Gut, and this is a classification of the post-EMR defect. It's very important to examine the post-EMR defect, and what we're looking for is the bland blue mat. We see the intersecting fibres of the luceralia connective tissue, the submucosa, and the blue staining, and if there's a disruption to that, either there's non-staining of the muscle layer or you've injured the muscle layer, or the muscle layer could have some fibrosis, and then it makes it hard to interpret whether the muscle layer has been injured. So we have the obvious hole, which of course can be fixed up, and the risk factors for these events are in fact transverse colon location because of the intraperitoneal location of the colon, aspirating gas, closing the snare, sometimes you can capture the muscle. High-grade dysplasia or cancer because of the desmoplastic reaction in the stroma, which sticks the muscle to the mucosa, and also attempted en-bloc resection. So if you really go for gold with the snare, you create a risk. But this can be dealt with easily now. I think everyone is now very comfortable with clip closure, and it's very safe in the colon. We need to recognise that these manifestations can be quite subtle. So here is the target sign that we described way back in 2010 or so. And you can see that this is really subtle, and if you don't look carefully, you say, well, that's nothing. But actually, this is a disc of muscle that's been excised here, and this patient will come back with a delayed perforation unless we recognise this subtle sign. And then this other one is the type 2 DMI, which is the submucosal fibrosis. We can't be sure that there isn't some injury to the muscle layer in all of these examples because the muscle is adherent to the submucosa. Maybe it's injured with diathermy or in some way. And so it's best to focally close that aspect of the defect as I demonstrate here. Ensure the first surveillance is done by the EMR endoscopist at 6 months, and you must be able to recognise the post-EMR scar and its various features and interrogate it very carefully. Recurrence can be treated very easily. I think in the future, these patients, perhaps they come at 6 months and then at 3 to 5 years with this snare tick technique, and standardised imaging is very accurate in detecting recurrence. This is work from our department. A negative examination with high definition white light and then MBI has a 99% predictive value for the absence of recurrence, and obvious recurrence here, but something subtle, potentially subtle here, and then under MBI it's very obvious recurrence, very obvious recurrence here. So flat recurrence is what MBI detects, so you need to use that technique. When we have recurrence, we don't need to do ESD. We can treat it by what we call cast. This is a technique for treating stuck down areas, and it's just published in Endoscopy. So here, this is a case from one of our surgeons. We excise these areas around the side, and then we use cold forceps avulsion of this area, and then treat the margins and close up the defect. Here's another example. Scarred centrally because someone attacked it with a snare but had no chance of removing all of it, and then we're left with this very difficult situation, completely stuck down area here, impossible to resect, possibly even by ESD, so we use forceps avulsion. It's amazing how when this is freed up laterally, it just peels off so easily, and then we can do adjuvant thermal ablation over the top. Finally, what about the role of Emr versus Esd? So Professor Yahagi nailed me at this arm wrestle. He's a very strong guy, and but I have the data on my side. So so we do a lot of ESD, and it's a completely different situation in the upper GI where ESD was developed. Of course, any demarcated dysplasia in the stomach should be treated by ESD, and a lot of lesions in the esophagus need to be treated this way. And we do many of these cases, and this is something that I truly enjoy. I love ESD with all my heart and soul. But I also want to do the right thing by the patient. And so we have to decide, is it the right treatment? And in fact, most colonic lesions are not invasive cancer. The frequency of invasive cancer in our large experience of more than 3,000 cases in the ACE cohort is less than 8%, and most of them are not low-risk submucosal invasive cancer. So we have to be logical. We have to use evidence. We know that ESD done by Western endoscopists is not as good as our Asian counterparts, and the results from Asia are probably even better than they're reported here, certainly by the experts that we have at this meeting. But there is a risk of perforation. It mandates multi-day hospital admission, and whereas EMR can effectively treat the majority. How frequent is low-risk submucosal invasive cancer? Even in the key studies from Asia, it's relatively infrequent, so less than 10%, 5 to 10%. So we did this modelling based on our work at Westmead, based on 1,500 cases, and we looked at wide-field EMR versus selective ESD versus universal ESD. So ESD applied to everyone versus selective ESD, those where we thought there was cancer, and wide-field EMR. We looked at all the costs and all the outcomes. And not to bore you with the results, it's published in Gut now, you can look it up. Selective ESD is actually the preferred strategy. So if we can select these cases, this provides the best outcome for the patient. But even with selective ESD, the incremental cost per surgery avoided is $210,000 per patient. So this is very expensive, and only 13 additional surgeries are avoided, and we have to do 350 ESDs, and of those, more than 300 of them don't have cancer. However, in the rectum, there's definitely a benefit, and this is the key sensitivity analysis. So selective ESD is optimal, but it can only be supported in tertiary centres. ESD is relatively primarily effective in the rectum, and a universal approach could be considered amongst high-risk lesions, and wide-field EMR is really the best way to go. There are a number of editorials which have just appeared from other experts in the world supporting this position based on different papers, meta-analysis and so on. What about, so sometimes we have to think, perfection is the enemy of the good, as Voltaire first enunciated, or in fact Shakespeare first enunciated in King Lear. And these are other editorials we've written on the subject. So sometimes when we seek to be perfect, we don't do the right thing by the patient nor the health service. So we have to engage in this idea of precision medicine. We have to apply the best evidence to achieve the best outcome for the patient. When we see flat lesions, we can confidently predict if there's invasive disease in a perfectly flat lesion using advanced imaging like we've discussed. It's really a little bit like a pizza. Sorry to bring the food analogy in before lunch, but when you look at a pizza, you can tell what the toppings are. You're never surprised when you eat a pizza that there's something hidden underneath that you didn't suspect. When we have bulky lesions, it's more difficult. And these are the lesions where perhaps some form of stratification of risk would be useful. So this is, to use the Italian food analogy, this is more like a calzone. rather than a pizza. You can't tell what's hidden inside, and maybe we need to have a means by which we can stratify. So for example, this lesion, a flat lesion with a demarcated area like so, this should at least be high-grade dysplasia, probable superficial submucosal invasive cancer. So in our department, this is treated by ESD, and the patient has in fact got cancer and was cured. And this paper we just published in Gastroenterology, based on 2,500 cases, and we stratified the risk for invasive disease in covert situations, so where we couldn't see cancer. So we took all the cases, we excluded the ones where we thought was cancer, and we looked at the ones where we couldn't detect cancer, and you can see the risk factors are these non-granular morphologies, bulky disease, 1S, so 2A plus 1S, or 1S, or in larger 2A plus 1S granular lesions. So we propose now that in the right colon, we can still do EMR because the risk of right hemicolectomy is minimal, but perhaps there's a role for ESD in the left colon, distal left colon and rectum because of the morbidity of low anterior resection and proctectomy. But this needs to be carefully studied going forward in careful prospective trials, and really it's still just a subgroup. Overall, most lesions do not contain cancer, and we can be confident they don't contain cancer. They can be effectively treated by EMR, and with these other techniques that I discussed, we can be free of recurrence going forward. There are other techniques coming that will make ESD easier. You've heard about pocket ESD. Unfortunately, retrospective analysis by Yamamoto, the inventor, but shows that it's faster. So we also do this technique in some select cases, like so, for a huge rectal lesion involving most of the circumference, large nodules, 2A, 1S, granular mixed nodular, perhaps best treated by ESD. And here's another example, treated in that way. And also this is traction-assisted ESD, I think, which will revolutionise the technique, make it much faster. So in summary, I think careful lesion assessment is crucial. EMR is the mainstay of therapy, and it's not difficult. You just need to follow this simple process which has been carefully outlined in the literature. Technique is critical to achieve the best results. Recurrence can be negligible with thermal ablation of the post-EMR margin, which will become the mainstay. And ESD has a limited role in selected referral centres for high-risk lesions in the left colon, distal rectum. Thank you. If you've got nothing to do in March, or indeed next March, then please do consider to come to Sydney. It's beautiful, beautiful in March, Sydney. Beautiful all the time, but particularly in March. And we have a fantastic meeting, and I hope to see you there. Thank you very much.